Good morning. We're going to talk about COVID today. This is a 2021 update coming to you from Joplin, Missouri. In way of introduction, my name is Dr. Rob McNabb. I'm a board-certified internal medicine physician for the past 16 years. My personal philosophy is lifestyle is always the best medicine. My primary focus in my career has been education, especially at the graduate medical education level. And my favorite word is gratitude. An outline of what we're going to go over is included here. So looking at the data for Missouri as of January 2021, what we can see is that October through December represented our highest peak, and that into January we're actually seeing a nice descent in overall new cases, which has been absolutely wonderful in our area of the world. And because of that, we've seen this rise in death toll, which is now starting to also slowly come back down as well, which is even better. Prior to 2019, when we talked about coronaviruses, we were really having a conversation about viral bronchitis or head colds. There's at any point in time about 4 variants of coronavirus that are in our area and in our communities. And they've always been fairly benign. We see them typically in the fall and the winter. And prior to 2019, as I said, they were a pretty benign experience for all of us. But obviously, as we're all aware, in 2019, with the new variant of SARS-CoV-2, this became a much more infectious and certainly much more lethal virus. So this is an RNA-enclosed viral subsection of coronaviruses, and known famously for these spike proteins, which we've all seen many times in many representations. The vector for the coronavirus really falls into 2 main camps. Mammals of many species and then bird species are all very well adapted to host the virus and then to spread viral particles. The incubation period of time for the virus can be up to around 10 to 14 days, but most people manifest symptoms around days 4 and 5. And of course, we know that the infection in most infectious portion certainly starts prior to the onset of symptoms. And in fact, in many patients, 40% of the population that are actively infected are asymptomatic but infectious. The key to really understanding what we see when we talk about the spread of symptomatology involved with SARS-CoV-2 can really be tracked back to understanding its relationship to this ACE2 receptors, or angiotensin converting enzyme 2 receptors. And so this receptor on any cell that you find it on is going to be the gateway receptor to allow SARS-CoV-2 to enter the cytoplasm, take over control of our reproductive system in the cell, and regenerate its own proteins to produce more viable viral particles. So the ACE receptor and where we find it geographically in organ systems defines which of our major systems are going to be susceptible to infection. And then the other thing to know is that you could certainly think of these receptors as a doorknob into the cell, but the receptor itself also regulates angiotensin converting enzyme 2. And so when these receptors are used up by these viral particles, they're no longer there to serve that primary purpose. And an overbalance of ACE2 does lead to a very pro-inflammatory state, which probably does add to the clinical syndrome that we see. So where are these ACE2 receptors found? Well, unfortunately for us, we can see that many of our most precious organ systems are the culprits. This is where we find the propensity of these ACE2 receptors. Now, I think that it's really important for us, whether we're in the medical community or whether we are not, that we really understand inflammation and its impact in this and many other disease processes. So inflammation is not the effect of the infection. It is in fact an immune response to try to clear an infection. It's a vital part of our immune response to any type of invasion. And what it's trying to accomplish is to destroy the invading organism, clear out any necrotic or damaged cells so that we can then initiate tissue repair. But the degree of inflammation that we see can define, in part, the severity of the illness, especially when you look at the other half of the equation, which is how functional was that organ to begin with? Now, most of us have far more abundant organ function than we actually need to survive. And so if you start an infection with a very healthy organ system and you get minor to moderate inflammatory response, well, you probably still have an abundance of function that's going to keep you away from an emergency or a potentially mortal situation. But what if you have really severe inflammation, or what if you have very damaged chronic organ disease? Well, you might not have that extra capacity to be able to afford to lose that temporary with the inflammation. And so this balance of inflammation to overall robustness of organ function really in part defines how clinically ill are we going to see our patients when they present. So let's take a look at the risk factors for those who are going to turn out to be at risk for severe COVID disease. So age plays an important part. Starting at the age of 35, we know that our immune system response to major challenges like sepsis starts to wane. So the older you get, the less robust your response is going to be. And I think it's worth noting that in the United States, 34% of citizens are older than 50, so 1 in 3. We've had significant graying of our communities. There's a preponderance of cardiovascular disease. Obviously, this is the #1 killer of adult Americans, so no shortage of that. Diabetes, if you add up everybody on the insulin resistant spectrum, you're talking about 40% of our citizens. Hypertension involves 1/3 of all Americans and 1 in 2 adults. Chronic lung disease certainly has a role to play here. Cancer is also an immune challenge to our system. Chronic kidney disease is certainly prevalent in the older population as well. Obesity, we just have to own this. 1 in 3 Americans meet the criteria by BMI for obesity. And then even though smoking is on the decline, you can see the numbers there, it still represents somewhere slightly north of about 10% of the American population. And so I put these on here to highlight, one, what are the risk factors for severe COVID, but also to get us to acknowledge that coming into this pandemic, the American population was not in robust health and not well suited to deal with a pandemic challenge. So let's take a look at these COVID syndromes. What are we likely to see clinically? So the first thing I want to focus in on is this generalized systemic inflammatory response syndrome, or for those in the medical community, we would call this SIRS. So if you're a layperson in the community, you would call this feeling like you had the flu or fluish. So significant fevers, dull headache, chills and rigors, significant fatigue, and then just body aches. And these are the symptoms that we kind of think of as the flu. And this is because of the immune response to the viral invader. So interferon levels are sky high, tumor necrosis factor starts to climb. And these are tools that our immune system is using to fight off this infection, or at least to combat it. And they are generating these symptoms. And in COVID particularly, this can be very pronounced. Your patients primarily are going to complain of a lot of these SIRS type symptoms. Now, the main reason why we talk about COVID at all is because of the severe impact that it can have on pulmonary systems. And it can be very much a spectrum of disease. So from a very benign upper respiratory tract infection, or perhaps we should call that a bronchitis type presentation, all the way to acute respiratory distress and just complete respiratory failure. So I put this slide on here because I think it highlights some things that clinically can be very useful to us. So this is highlights some of the subtle differences of COVID versus influenza because they're sharing a season, at least currently. And so both of these are fair game for differentials for why does your patient present with pulmonary symptoms. So some things I really want to call out and highlight for us would be the difference in onset of symptoms. So with COVID-19 as compared to influenza, COVID is a very gradual in onset. It's insidious. So the symptoms might be a little bit of chills one day, and then slow little body ache or headache, and then it kind of crescendos up over a 3 or 4 day period of time. Very easy to ignore for at least a day or two. Whereas influenza, many times in my clinical career, I have described influenza like a Mack truck. You're fine, and then that truck hits you, and you are not fine. And so influenza comes on very, very abruptly, very hard, and this is very different than what I've seen with the COVID viral experience. It's something to note that with COVID, I'm sure we've all heard this called out many times, that this loss of taste or smell is a known issue with COVID, and it seems to be somewhat specific to it. I would tell you that initially I thought that this might be because of nasal congestion, just impeding function of the sinuses, but that's not what's happening. COVID-19 is causing a neuropathy in some of these cranial nerves, and this is actually a neural deficit. So these people can move air just fine. They just do not have the neural response that they should when they function normally. Whereas when you look at the influenza population, rhinorrhea, nasal turbinates, stuffiness, edema in the airway, these are pretty common for influenza. So those are some of the few differences that kind of stand out to me, at least, when you're looking at these two viral syndromes side by side. So I put this chest X-ray up, which is a very normal chest X-ray for those who either don't have much experience looking at films, and we're also going to use this as a comparison against X-rays that have more pathology. And so this is a simple one-view chest X-ray. These are the diaphragms, the muscle that helps us breathe. Here's your heart, here's your spine, here's your rib cage. And you can see that these are just gorgeous, well-inflated lungs. These linear things that you see here are blood vessels coursing throughout the lungs. And so this is what normal should look like on a chest X-ray. Well, when we develop pulmonary issues due to COVID, the thing that happens is inflammation causes leak from the blood vessels, and you start to see these patchy pockets of fluids starting to flow into the spongy lung material. And as this happens, it really starts to impede our ability to exchange gas, whether that's oxygen or CO2. And the amount of lung tissue that's being hampered by this inflammatory fluid collections really defines how ill is this person's pulmonary system going to get. For example, this would be a really good X-ray representation of acute respiratory distress syndrome. It's similar in pathophysiology to the previous film, but much, much worse in degrees of severity. As you can see, there's not a lot of normal unaffected lung tissue in either of these films here. So you can imagine as we run out of lung real estate, that gas exchange can be severely impeded to a point where vital sign safety is not able to be maintained without really extreme heroic procedures. And the other thing to know is that for those patients who do survive severe COVID, that we are starting to see that there is some degree of residual organ damage. So what you see here in this film, this honeycombing that's kind of on the periphery of this lung tissue, you can see it here as well. This is scar tissue, or we would call that pulmonary fibrosis. So this is a permanent scar, a permanent derangement of lung anatomy that this person is going to be dealing with for the rest of their life. And this obviously is not going to turn out to be functional the way that this normal preserved lung tissue is going to be. And when you look at the overall amount of lung scarring that this patient has experienced, that's a fair amount of lung territory that's been compromised. So let's move on a little bit. So cardiac issues have been well documented in the literature as well. They range a spectrum of presentations, so we'll go over them briefly. First is myocardial infarctions. So we know that coronavirus is associated with a prothrombotic state, or another way to say that is when you have this much inflammation, you are more likely to produce blood clots. And so certainly those blood clots could involve your coronary arteries, and if so, that can absolutely induce a myocardial infarction or heart attack. Other ways where this virus can also cause these issues, let's think about the patient who already has history of coronary disease, already has obstructive diseased blood vessels, and then you throw them under the massive strain of having a viral infection. That extra strain on the heart, that extra work it has to do, certainly could be enough to provoke a heart attack as well. Now, this is something that we talk about a lot less, but I think that we're going to hear more of as we go through time. So this is a cardiac MRI, and what you see is that this white appearing tissue in this heart is inflammation. And so this is inflammation of the myocardium, or the muscle of the heart. And we don't really know what to make out of this right now. There have been studies looking at collegiate level athletes post-COVID infection who are asymptomatic. But when you look at MRIs of their heart tissue, somewhere upwards of 50% of them still show inflammation. And clinically, we don't know what to make out of this. Does this mean they're at more risk for a cardiac issue if you put them back in play and they're aggressively exercising or competing? Could this lead to a cardiac arrhythmia? We really don't know. There's a lot of study that needs to be performed to really be able to evaluate the risk and benefit ratio of how we handle myocarditis in this population. So a lot of work to be done. This is an example of two echocardiograms. The one on the left here is a pretty normal looking functioning heart. So you can see that the heart is pumping, the walls are squeezing, this chamber is where the blood is being pumped out really well. And so even if we're not cardiologists, we can probably look at this and say, okay, if this is normal, what's going on here? Well, we can see these walls are just not squeezing the same. I mean, this heart is really struggling to be able to pump blood at all. So this would be an example of a cardiomyopathy or heart failure induced by the virus itself. Now, in some people, this may be a temporary decrease in function, and in some people, this may be a very permanent decrease in function, and then this is going to absolutely affect the quality of their life. Fortunately for us, the nervous system is also able to manifest infection from coronavirus, but we don't see it as commonly as we do other syndromes. So that is a blessing for us. The most common things that I do see in my own clinical practice and in the literature is certainly these neuropathies. So, lack of our ability to smell and taste appropriately. Certainly seen a significant amount of delirium in the acute phase of the virus. More rarely, I have seen a number of strokes, especially in those with severe inflammation in the system. And even more rarely, I have seen a few movement disorders, patients with new onset severe tremors that impact their ability to take care of their activities of daily living. And the literature does support that there are some associated Guillain-Barré syndromes with COVID infections as well. Typically, when I see acute presentations in the hospital setting, they are either going to present as pulmonary symptoms, and I would say that's about 70% of the time. The other 30% of the time, what I'm typically seeing is GI symptoms. So this is my number 2 way to see these patients roll into the hospital. And they typically will present with nausea, abdominal discomfort, and then diarrhea. And so, for myself and for my fellow hospitalists and my resident trainees, I do warn them if gastroenteritis is the presentation that you're looking at, you still need to be on guard against COVID as a potential etiology, because it's not that uncommon a presentation. Now, the good news about COVID is that this pie chart has not changed much over the past year. We know that more than 80% of people that acquire this infection are going to have a very mild disease course, are not going to require hospitalization, and are going to go on and do just fine. About 14% of these people will develop severe disease and are going to end up hospitalized for at least some period of time. About 5% of people will be critical and are going to probably end up on ventilators. And then about slightly over 2% of all comers will go on to have a fatal course. So when we think about treatment options for our patients, it's really based upon the severity of the symptoms and its impact on your overall ability to operate your organ systems. And so for those who are mild or moderate, the first thing that we need to really assess is their risk of going on to have more severe disease. And that's based upon these risk factors, which we've already examined in previous slides. So if you're at very low risk to progress on, then really supportive outpatient care, rest, chicken noodle soup, we know what this looks like. That's really about all that's really required. You do need your 10 days worth of isolation from onset of symptoms, but that's really all that's really required for the vast majority of these patients. However, if you do meet the risk factor criteria, then there are outpatient treatments with monoclonal antibody therapies, which can be, in my experience, extremely effective. So in this region, we're utilizing a monoclonal antibody treatment called bamlanivimab, which is a synthetic immunoglobulin which does target the virus itself. And these immunoglobulins are actively destructive to the virus itself. But of course, the immunoglobulin response is always augmented by helping other portions of our immune system target and actively destroy the viral invader as well. Now, this is of course anecdotally my experience after having many outpatients utilize this therapy that typically within 24 hours, they feel appreciably better. I wouldn't say back to baseline, but 60 to 80% better. And that's been a recurrent with all of my patients. And to this date, I've not had anybody go on to have this therapy who then worsened to the point where they needed to come into the hospital setting. So I'm a tremendous fan of this treatment. You know, when we think about what's going on inside of our body, kind of like a foot race between viral production and immune response is what's happening. And so anything that we can do to increase the speed of immune response is going to help us slow down viral reproduction and bring it to a halt. And I think that the early use of monoclonal antibody therapy seems to be really potent when you use it in that time frame. So the earlier, the better you can really make a tremendous impact for these patients. So I've been super pleased with these treatments. For our patients who have severe or critical disease, they're going to end up hospitalized for a period of time, and they're going to need a lot of supportive and therapeutic treatments offered to them. We're going to go through those now. So typically in any setting, these patients are going to be placed into an isolation unit. These are reverse environmental units with negative pressure systems. There is significant amount of training in the use of protective personal equipment that are required for you and your healthcare team to be able to operate safely and effectively in these units. Very important to master this if you're going to be working with these patients. We have some pretty advanced equipment that we have utilized over the past year. These are called PAPRs, and this is a filter on the back of this gentleman's harness here that's pulling air into the system through a filter and then pumped up to his helmet and then back out again. So this can be very, very useful, especially if you're going to be doing a lot of procedures on an infected patient, or if you're in that patient's environment for a protracted period of your clinical time. These ventilator pumps are very important. So in the isolation units that I've been affiliated with, all the units have multiple pumps in the unit themselves, and each individual room also has their own pumps. These particular pumps have a series of 6 or 7 HEPA filters in them, so they're pulling air through all of those series of filters and then evacuating outside of the building. So the air in the hospital is being pulled into the unit and then into the rooms, filtered, and then cleared out of the hospital completely. These are very noisy, by the way. It really is a unit that has a lot of sensory issues. The pumps are loud. The amount of PPE that you're wearing, especially the PAPRs, can make it very difficult for you to hear. So communication can be a little bit impeded when you're in these isolation units. So now let's move on to specifics of treatment. So there really are a lot of what I would call disinformation out there, or bad information, or information without evidence. So what I'd like to share with you as of January 2021, here's what the CDC says that has evidence that it works and is worth doing, and what does not. So when we think about this virus, we've had a lot of conversation about inflammations and severity of inflammation. So it really shouldn't be too surprising to us that something like dexamethasone, which is a really potent steroid or anti-inflammatory, is going to have a major role to play. So if your patient is hypoxic and requiring supplemental oxygen, then there's great evidence to support that some degree of dexamethasone is worth your while. Now, I will say in most places that I've looked at their literature, they start at about 6 milligrams, and so we kind of get it into this idea that 6 milligrams of dexamethasone per day is the dose. But when you actually look at the meta-analysis worldwide, there's a spectrum of treatment ranging from 6 milligrams per day all the way up to about 20 milligrams per day. And there's also some evidence to suggest that accelerating the dose over the clinical course may also have some benefit in some cases as well. So not beyond the pale of reasonableness to consider. Dexamethasone is definitely a workhorse for us. Now, we also talked about that race of viral production to immune response. So that's where remdesivir comes in. So what this medication does for us is it inhibits the viral proteins from being reassembled into a viral or a viable viral particle. So if I can stop you from taking the pieces and putting it together, then we're going to slow down the production of virus to the point that hopefully our immune system can get a leg up, get ahead of the spread, and start to really rein it back in again. So this is what we use remdesivir for. It's typically once a day treatment for 5 days, which can then be extended out to 10 days if clinically warranted. Convalescent plasma is also something that you probably have already seen or will see in clinical practice. I've certainly prescribed my fair share of it. I'll be honest with you, by the time these patients are severely ill and in the hospital, I really have not been particularly impressed with the healing properties of convalescent plasma. There's some question, especially early on, whether the immunoglobulin titers per bag was variable, and that might have led to this variability of effectiveness. Certainly possible. I will say that in a pinch, I will continue to do it. You know, if I run out of other options, it's not a major detriment to using it on your patients. But I would point out, when you look at the CDC website, that really, you know, they're pretty blasé about its use. There's insufficient data to recommend against or for its use. So it's a user beware and use at your own clinical discretion. But in my clinical experience, I really have not been incredibly impressed with the use of convalescent plasma. Now, there are things that just don't make the cut, guys. You see all kinds of things out there. Early on, you know, we trialed hydroxychloroquine with or without the use of azithromycin. The lion's share of the evidence does not bear its use, and in fact, the CDC clearly recommends against the use of chloroquine in this patient population, and I've used it, and I can tell you that in chasing around the myriad of cardiac arrhythmias that plague these patients, I really have some real questions how much of that was the severity of their illness and how much of it was the hydroxychloroquine. I think at this point, most practitioners who are keeping up with the current literature would not recommend this for use for treatment of COVID. There also is no good evidence to support the idea of other antivirals like the HIV protease inhibitors. It's clearly recommended against the use in COVID patients for that treatment. Now, if you come in and are HIV positive and have COVID, that is a completely different scenario that we are not addressing today. But if the use of this medication is in an attempt to treat COVID, the evidence does not support that there will be a positive outcome. There's also been a upsurge in interest lately about ivermectin and its potential use. Right now, The CDC is recommending against the use of ivermectin unless you're involved in one of the clinical trials taking a look at this, but there's just not enough evidence to recommend for it, and they are clearly recommending against it at this time. I would also note that there are a lot of other things along the lines of supplements like zinc, vitamin C, vitamin D, and right now the CDC does not particularly recommend the use of any of those supplements as being beneficial, and specifically recommends against the use of zinc. Now, I think the most important thing in treating your patients on the inpatient side with COVID is this acknowledgement that this disease takes time to improve. You know, the average length of stay, in my experience, for a COVID patient is about 11 days. And we should contrast that with the average length of stay of every other hospitalized patient for any other diagnosis is about 4 to 5 days. So this is a disease that takes a long time to improve clinically. And you just need to acknowledge that and hold on to that thought. You know, primary for us should be focusing in on keeping our patient stable and supporting them so that they can do the hard work of making it through that period of time to improvement. So I think the tincture of time is definitely one of the best tools that allows our patients to get better and get out of the hospital. But boy, it really is difficult to take care of these patients on a day-to-day basis and not see rapid improvement the way that you would like to, and fight that urge to think I should do more when some of those things that you may consider doing don't have much evidence to support that they're clinically of usefulness to your patient. We just have to adopt the idea that time is what it takes, and we need to be patient and supportive of our patient. All right, let's switch gears and let's get educated on these vaccinations and what do we need to know. So briefly, in talking about older vaccinations, you know, we've had about 3 major routes by which we have produced the vaccinations that we're most familiar with. You know, we use these inactivated viruses, or you or I may call this a killed virus or a dead virus, or we may damage a virus or attenuate it. So this is a weakened virus, so no longer strong enough to cause a major health issue to the host, or we may take a protein chunk off of a virus. And in any of these cases, what we end up doing is exposing our immune system to one of these invader stimulations: dead virus, damaged virus, chunk of a virus. And this is what allows our immune response to start. And so this is where we've been. This is how typically we make all the vaccinations that we use currently in clinical practice. But now we have this messenger RNA vaccination as of this year, and it's new, it's exciting, and of course with anything new and exciting there's some fear of the unknown. So a little bit of historical background for us. I think it's important to know that even though perhaps we've never heard of messenger RNA vaccinations prior to this year, it doesn't mean that the technology sprung up in whole cloth in 1 year. In fact, this research into building this technology has been going on for a little bit over a decade now. And in fact, you know, one of the major manufacturers in the United States in the market is Moderna, which is actually a wordplay of modified RNA. And this company has been in existence for more than a decade, focusing only on developing this technology and bringing it to the market. And so my point is that this technology has been worked on and fine-tuned for about a decade and is now ready for prime time use. the pandemic and the SARS-CoV-2 issue just is an amazing opportunity to utilize this technology. And so, when you think about that technology, the thing that we needed the target protein. So basically what we're doing is we're taking and building a synthetic RNA message or a sequence that then codes to produce that spike protein on the COVID viral particle. And then our own immune system will see these proteins that our body makes and then build an immune response against this, which is extremely exciting to think about the utility of that. As long as we have a library of mRNA messenger programs, for lack of a better word, we can build a vaccination to anything in the world, theoretically, and never have to go hunt down that virus and get a sample of that to bring back to build these vaccinations. So that's amazing. And of course, there's other applications as far as cancer treatments and that sort of thing. So very cool. Now, I think that the analogy that I would recommend that we use to think about these messenger RNA vaccinations and probably to explain them to our family or to our patients, I think that the computer to the printer is a great analogy. So the computer program sends a message to our printer and says, print me this document, and that's what the printer does for you. Now, there's been some concern in the news and in the communities about, is there a chance that this messenger RNA could permanently change our DNA? And if you think about the analogy of the computer and the printer, that would be analogous to saying, if I take a document and feed it backwards through the printer, that would then send a message back to the computer that then would change the computer program. And if that seems unlikely to you to happen in a computer, it's also not a possibility intracellularly. The issue would be that human beings do not have the cellular mechanisms, or programs for that matter, to reverse engineer RNA into DNA. That's not a thing. So it's physically impossible for us to do that. Now, there are certainly reverse transcriptase viruses that may be able to perform a trick like that, but human beings cannot. So it's simply impossible and not worth worrying about that an RNA could somehow permanently change our DNA library. That's just not a thing for us. So hopefully we can get that message out to our patient populations and people in our community so that they can also share that information and allay those fears of people who don't really understand the science that drives this technology. Now, I do want us to focus back on the inflammatory response of COVID. So I have noticed in my own experience and in working with people who've been vaccinated that the inflammatory response to the vaccination does seem to be much more pronounced than other vaccinations that we've experienced before. Certainly more swelling, more inflammation at the injection site, low-grade fevers, feeling fluish, headache, chills, the myalgias, all that. That certainly is a thing. And so we monitor these patients or anybody who gets vaccinated for at least 15 minutes. Now, there is some documentation as we are rolling out these vaccines worldwide that for patients who have a predisposition towards an anaphylactic reaction, that we're concerned about those patients. They may be at a little bit more risk to also develop a more severe allergic reaction. They just have that tendency. And so for those patients, they really need to be monitored for about 30 minutes. Probably not a bad idea for them to have a conversation with their healthcare providers about, do they need to do anything pre or post vaccination, or should they at least have their epinephrine pen available to them? Probably some fairly wise precautions to at least have that conversation and have a plan. But interestingly, there really have been minimal amounts of patient population that have had these anaphylactic reactions, a ratio of less than 1 to a million. There's only 20 or 30 documented worldwide as of the making of this presentation, and there's not been a single fatality. So about 17 people ended up hospitalized overnight briefly just to be sure that they did fine, and they did. So I think that as long as you understand your patients or your own personal risk and you have a plan, then I think that this is a safe vaccination, and we should definitely encourage our patients to move forward with that. Before we move on to the next part of the conversation, I do want to point out that in special populations such as the pregnant population or breastfeeding mothers, that ACOG or the obstetrical societies have come out with a very strong position that they are recommending these vaccinations to young mothers, that they are felt to be very safe for the mother and for the baby, and it's a strong recommendation that we encourage those patients to proceed on with the vaccinations. Now, having said that, I'd like to switch gears a little bit and educate a little bit on what we're really talking about when we say some of these vaccinations are 95% effective. So what are they effective at doing? Is it complete immunization? Well, interestingly, the answer is no. They're not 95% effective at making you immune to getting COVID, but what they are 95% effective against is you getting symptomatic COVID, which is subtly different. So, and here's why, guys. When you look at what happens after you get a vaccination, you're going to see a big spike in particularly one type of immunoglobulin or antibody, and it's IgG. And we should think about IgG as the antibody that polices our deep system and our organs, right? But IgA, which is not particularly well stimulated by the vaccination, is the immunoglobulin that tends to line our upper respiratory tracts, our sinuses, our mouth, upper airway. And so because of this phenomenon, what we have found is that people or test subjects, animals that have been vaccinated, they are resistant to developing symptomatic COVID. And when you look at these patients, you can't find the viral particles in their bloodstream, you can't find them at the organ level. But when you swab their sinuses, there have been cases where we find that, yep, in your sinuses there is some viral reproduction, and theoretically that's a viable source of viral exposure. So even though you may look good, you may feel excellent and have no symptomatic complaints, that virus, because of this lack of sustained IgA, could be utilizing your upper airway tract to reproduce anyway. And so when you look at the Moderna data from their trials, what you can see is, very few people that were vaccinated went on to have symptomatic infection. But look at the asymptomatic infection proportion of this graph. Certainly a difference there. So, well, what's the point? What's the take-home message there? Well, until both of these people are vaccinated, one of these people could still potentially be at risk. Now, we do think, and we do know, that being vaccinated does decrease your chances of actually acquiring the infection. But it's not 95%, right? So if this gentleman's vaccinated and he feels fine, but still has some viral reproduction in his respiratory tract, in his sinuses, this young lady who's not vaccinated could still potentially acquire the infection. So we need both of them to be vaccinated. We need a preponderance of our citizens to get vaccinated. And so until we get upwards of 70% of the population immune, whether that's through vaccination or whether that's through recovery from a primary infection, we're still going to have to follow these guidelines of interim masking, social distancing, and hand hygiene. So keep that in mind and make sure that you're able to educate your patient population, your loved ones, and members of your community about why that's still an issue despite the rollouts of the vaccinations. There's more to be done with all of that. All right, having said that, this is the end of our conversation about COVID. I'm sure that there are probably those of you who have additional or more specific questions that you'd like to have addressed. And so I would recommend to you that you should absolutely feel free to contact me with any other questions. This is my email address, so feel free to reach out. I will share with you what I know. I can't treat you or give you medical advice that you would need to go and get from your primary care physician, but I can definitely share with you what I know about COVID and its treatments and what I know about vaccinations. So with that being said, thank you for paying attention and listening. And again, feel free to contact me should you have any questions whatsoever.